and good to see all the familiar faces and to be at our last ECHO session of our positive behavioral interventions and supports ECHO series. So at this point, you already know the kind of the routine. Your microphone has been muted, but feel free to chat in. And at the time when we have discussions, also please feel free to unmute yourself to chime in as well. We would love to keep your cameras on so we can see your faces and have a really have a more community. But if you are not able to be not in the appropriate environment, we totally understand as well. So at the end of the ECHO series, which, again, today is the last session. So thank you again for all being here and also for, staying with us for the entire series throughout the year. And we will be able to provide a certificate of attendance that lists all the sessions that you have attended and the hours as well. So making sure that, of course, you registered and also have your name appeared correctly. Again, just want to acknowledge that the ECHO series has been supported by the Cigna grant, and also we are part of the KU Pediatrics and then the K card. Next slide. So today, Dr. Linda Hasenpao and I will be hosting for the first half. And we want to be upfront and apologizing that we have to kind of leave in the middle because we have a conference presentation that happens at the same time. So we just want to say ahead of time, and we really, really appreciate you all. And we have our wonderful presenter, Dr. Ellerbeck, here today. And she is a wonderful developmental pediatrician at the KU Medical Center. And I will have her own introduction a little bit later, but I just want to go through the logistics first. So if you, I know that at this point, you have attended many sessions. So if you can just put your name and in the chat and which organization that you are affiliated with and what you are hoping getting out of this session particular, that'd be wonderful. So we can, again, have that communication. So the agenda to today is that in addition to the introduction we are doing right now, we're going to have a didactic presentation from Dr. Ellerbeck, and we will have a case presentation. And after that, we would love to hear from Dr. Ellerbeck, but also from you all in terms of questions and inputs, suggestions as well. And we will be able to have a summary of recommendations to be emailed to the case presenter. And on the PowerPoints, on the right side, there's a level up sign. So when you see this sign, we really want to hear from you. There might be questions that would love to have your input. So feel free to chat in anytime. And thank you for you putting your information in there, Susan, John, and again, appreciate you all have been helping us collecting data. So after this session, because this is the last session, we would be send out a survey link that asks you for your feedback about your experience with the entire ECHO series. And we would so appreciate you filling that survey back so that we can have the data and we can continue to apply funding and then provide educational series and ECHOs like this. So thank you for doing that. Next slide. And although we are, this is our last ECHO session, we are not doing case presentation anymore, but we're still, providing that free case consultation that can be one-on-one with clinicians and providers. So keep that in mind. And if you have a case that you would like some input from us, feel free to contact us and let us know. We would love to talk with you in more depth. Next slide. Okay, I will turn the mic to Dr. Ellerbeck.
Hi there. My name is Kathy Ellerbeck. I am a developmental behavioral pediatrician. As Alice said, I've been here a while. I trained in pediatrics. To do developmental behavioral pediatrics, you do a pediatric residency and then a fellowship in developmental behavioral. I did that a very long time ago. So I've been in practice since the mid 1990s. And for more than 20 years, I've worked here at the University of Kansas. I love where I work because I work on interdisciplinary diagnostic teams. So I work with psychologists and speech and language pathologists and social workers, and I appreciate all that expertise. I do quite a bit of medication management for children and adults with intellectual disability and autism spectrum disorder. Again, I consider myself fortunate to work with psychologists who provide evidence-based behavioral interventions, because I think behavioral interventions are often much more powerful than what I have to offer with medications. But that being said, there are some children with internalizing and externalizing behaviors who benefit from medical assessment and intervention in addition to behavioral therapy. So our key objectives today are to know how co-occurring medical conditions can impact behavior in persons with neurodevelopmental disorders, to understand the role that pediatricians and other medical providers might play in identifying and treating medical problems, and then learning about the role of medication management in behaviors presenting in persons with neurodevelopmental disability. So neurodevelopmental disorders, the DSM-5 was published in 2013 with a new chapter called Neurodevelopmental Disorders. Today, I'm going to primarily talk about intellectual disability and autism spectrum disorder, and actually more about autism spectrum disorder. But I'm going to go through some definitions first. And I know you may already know this, but global developmental delay is defined as delay in 2 or more developmental domains. We use that particularly for young children. IQ isn't stable until at least age 6, and we don't diagnose intellectual disability, which we used to call mental retardation, in young children. Some young children grow out of their delays. Others go on to have more of a learning disability and not an intellectual disability. But intellectual disability or global developmental delay is a risk factor for intellectual disability. Intellectual disability used to be called mental retardation and is defined as disability characterized by limitations in both intellectual function and adaptive behavior. And autism spectrum disorder. First things first, let's define that. There has been more research on co-occurring conditions, medical and mental health, in the autism literature than in the literature for intellectual disability. And I'm going to present a practice pathway today from the Autism Treatment Network that I think is also applicable in many ways to persons with intellectual disabilities, so not just necessarily autism. Autism, though, is characterized by persistent deficits in social communication and social interaction, and restricted and repetitive patterns of behavior, interests, and activities. Hang on a second, there we are. And so in our clinic, we do spend a lot of time looking at diagnostic criteria and doing diagnosis, which is not a role that necessarily a general pediatrician would do. We also, when we characterize children, we characterize specifiers. I love the DSM-5 in that it allows us to describe a child in a much more comprehensive way compared to the older DSM-5 classification systems. So today I'm not going to really talk about diagnosis of autism spectrum disorder very much, but I'm going to talk about those specifiers or co-occurring conditions. So what might the role of the pediatrician be? Physicians, and not just developmental behavioral pediatricians, can help with the identification of etiology or underlying cause and find genetic syndromes. It's important, and we'll talk about the recognition and treatment of medical comorbidities, and then diagnosis and management of co-occurring mental health and psychiatric disorders. So our first objective is to talk about co-occurring medical conditions. They're somewhere between 5 and 15% of persons with autism spectrum disorder. If you did genetic testing, you might find an identifiable cause. And that can sometimes be helpful, and we'll talk about that. Children with spectrum disorder are at increased risk for seizure disorder, and medical conditions, you may need a neurologist as well as a pediatrician to manage those. And children with autism spectrum disorders often are at increased risk for tic disorders as well, motor tics, vocal tics, Tourette syndrome. But that's not the big part that general pediatricians do. The majority of children with spectrum disorder have some problems with food refusal, GI problems, or sleep problems. So how might those problems affect behavior? Sleep disorders, if you have a sleep disorder, it's known to be associated with increased anxiety and sensory over-responsivity, aggression, self-injury, and difficulties with emotion regulation and behavior. And you think about how if you get no sleep, you might have some of that same stuff. So sleep disorders are really important. Constipation is associated with increased prevalence of difficult behaviors. If you look at scores in the research on the ABC, you'll certainly see increased irritability, social withdrawal, stereotypy, and hyperactivity in kids who have significant constipation. And then there are very picky eaters who have autism spectrum disorder, and there are some associations between restrictive eating, sleep disorders, and restrictive eating and constipation as well. So why might underlying cause matter? A couple of reasons. Prematurity can be associated with increased risk for autism and ADHD and learning problems. And so if you have a child who is born extremely prematurely, it may be helpful to look at those factors and think about that. There also are genetic syndromes that can be associated with increased risk for autism, with co-occurring medical problems, and even certain behavioral phenotypes. For example, if you were to identify a child who had Fragile X syndrome, you would know that that child might be at increased risk for anxiety disorders. A child who has a chromosome deletion that causes Phelan-McDermid syndrome might not only have autism, but might have a lot of sensory differences and under responsiveness to pain. Smith-Magenis syndrome is associated with sleep disorder and self-injurious behavior. So the Autism Speaks Treatment Network has a psychopharmacology committee which developed a practice pathway for individualized management of irritability and problem behavior. As I mentioned at the beginning, this could be used for persons with intellectual disability as well. And I'm going to talk much more about this when we get to talking about Objective 3 and co-occurring mental and mental health disorders. But I'm mentioning it here because the first thing it does, 5A, is to assess and address any current medical problems. So how do we do that? The way that we do that is a physician would conduct a good medical review of systems, which means we asked about everything from, do you have increased headache? Do you have problems with sleep? Do you have problems with anything that could cause pain? And then to treat that pain, treat seizures, treat sleep, treat GI, ear, nose, and throat, dental, and other medical conditions. This is particularly important if you have a child who has a real change in behavior. I had a young man who I followed now for many years who has severe autism, and a couple weeks ago, his mom said his behaviors were just so much worse, and we increased his meds, and then she figured out that he's constipated, and we fixed that, and that really fixed that. So looking at those things can be really important. And the other thing that happens is sometimes we use medications both for co-occurring mental health problems, but also sometimes for allergies or other things that can cause behavior problems. So thinking through and having a pediatrician think through what might be going on that's causing change in behavior. So as for children with other medical illnesses, I need subspecialist report. I'm a subspecialist in developmental behavioral, but I still need people who help me with GI problems, genetics, neurology, nutrition, and sleep. So many of these problems, a general pediatrician can help manage. Like I mentioned, constipation is very common in children with autism and also in children who don't have autism. And often a general pediatrician can help manage that. But there are kids who have more severe GI problems, including severe constipation, but also reflux or esophagitis, who may need a GI specialist. Genetics, a primary care pediatrician can do screening genetics, but sometimes you also want genetic counseling for family planning, or if you identify a certain syndrome that can have health supervision implications, and you may need a geneticist. Most pediatricians work together with a neurologist for management of seizure disorder. I refer a lot of our kids who have very picky eating to our nutritionist, because some of the kids, a lot of our kids are picky, and it's not really a safety issue, but some of our kids are so picky that nutrition is at risk. And then finally, pediatricians are very familiar with working with kids who have sleep disorders, but again, children with spectrum disorder often have sleep disorders that go above and beyond what a general pediatrician or a developmental behavioral pediatrician can do, and may need a sleep specialist. So the fortunate child with spectrum disorder has access to all this needed expertise. And again, the DSM-5, the specifiers, can really help you identify what expertise you need. So the third objective was to talk about co-occurring mental health problems in autism spectrum disorder, and the role of medication management in externalizing and internalizing behaviors. So how common are these co-occurring mental health disorders? Common. 70 to 72% of youth with autism spectrum disorder are thought to have at least one co-occurring psychiatric disorder. The most common co-occurring conditions: anxiety, mood disorder, obsessive compulsive disorder, which is sometimes very hard to differentiate from other sort of rigidity in autism, ADHD, and then oppositional defiant disorder is diagnosed by some, but again, that I think there may be better ways to think about disruptive behaviors in kids with spectrum. About 40% of youth with autism spectrum disorder have an anxiety disorder. So anxiety and ADHD are both very common, with population estimates or prevalence estimates of ADHD ranging from 21 to 30%, and even higher in clinical populations. And then depressive disorder is strongly linked to suicidal ideation, and the range is very wide in the literature, but there's increasing concern about the number of persons with spectrum disorder who have suicidal ideation. So there are some diagnostic challenges. Differential diagnosis is complicated by what they call diagnostic overshadowing, which is defined as attributing autism-related symptoms to a co-occurring disorder, or considering everything under the umbrella of autism. And it is helpful to try to pick that apart because it does help with treatment. So many individuals with autism have multiple co-occurring disorders, with an estimated 41% having 2 or more disorders and 24% 3 or more disorders. And I experience that in my clinical population. I frequently have kids with autism who have ADHD and anxiety, and sometimes depression as well. So emphasizing just looking at specific disorders, an alternative is to really emphasize symptoms that are shared across disorders. And that's why I like this irritability practice pathway that I'm going to show you some more about. There's a growing body of research that demonstrates that emotional regulation impairments underlie a lot of the common psychiatric disorders, and that gives some utility to emotion regulation focused treatment. So for this practice pathway, the definitions they used in the practice pathway were irritability, which refers to vocal and motor outbursts expressive of anger, frustration, and distress, often referred to as temper tantrums, meltdown, or rages by parents and other caretakers. Problem behavior refers to more directed acts of aggression that have a high potential of resulting in harm. And then most of these things co-occur, and so most of this algorithm talks about irritability problem behavior, which because it's too long to put in PowerPoints, is abbreviated as IPB. So, okay. Why did this practice pathway come about? The rationale for it was that Risperdal and Abilify are FDA approved for autism. They can be very effective in treating irritability, and that they are widely used in persons with autism spectrum disorder. But Risperdal and Abilify, which are atypical neuroleptics, really have a significant risk of metabolic and neurologic adverse events. And so the Autism Treatment Network recommends that we really consider lower risk interventions first, even for severe irritability and problem behavior. And so the Autism Speaks Treatment Network Psychopharmacology Committee, which is a mouthful, reviewed the literature on assessment and treatment of contributory factors for irritability and problem behavior and grouped them into 5 domains. And let me see where I am. There we are. So co-occurring medical conditions we've touched on already. And I know that during this ECHO series, you've talked a lot about functional communication and maladaptive reinforcement patterns. We also need to think about psychosocial stressors, especially if there's big change in behavior, and then co-occurring psychiatric conditions. And so for co-occurring medical conditions, we've talked about that and the role of physicians. There is also a significant role for management of co-occurring psychiatric conditions. That being said, when I'm seeing a patient who has a lot of irritability and problem behavior, I really appreciate getting information from providers who can give me information about functional communication and about reinforcement patterns. And if a caseworker or somebody knows the family well about psychosocial stressors, because that is not always available to me in other ways. So. Okay, so this is what the practice pathway looks like, and it's a very small print. So I know that I'm pretty sure that you have the article that this came from. So we talked about 5A, which is co-occurring medical conditions. We're going to spend some time now talking about co-occurring psychiatric disorders. And then we'll talk a little bit more specifically about the role of medication in children who have disruptive behaviors and autism. I would also say that when we talk about disruptive behaviors, kids kids in general, who have anxiety and depression don't always present the way that adults do and often present with irritability. So this isn't necessarily just limited to externalizing conditions like ADHD. So in the algorithm, 5A was co-occurring medical problems. 5E is assess and address any co-occurring psychiatric disorders. This is challenging in practice because there really aren't very good specific screens that help you differentiate that in persons with autism spectrum disorder. So we use some of the same tools that we use in children who don't have autism spectrum disorder. And then as indicated, treat or refer for treatment of co-occurring disorders with medication. And almost always, we also want people in behavioral therapy for specific identifiable mental health problems as well. So we're going to talk a little bit more specifically about ADHD, depression and anxiety, and suicidal ideation. Externalizing behaviors, ADHD is categorized as an externalizing behavior, whereas depression and anxiety are internalizing behaviors. Okay, for co-occurring ADHD, in the old days, when I was around, the DSM-4 did not allow diagnosis of ADHD if you had a child diagnosed with autism. This was a problem because everybody saw ADHD symptoms in children who had spectrum disorder, and the DSM-5 permits co-occurring ADHD as well as other co-occurring mental health disorders. I mentioned that the prevalence estimate varied to between 21 to 30% in the population-based estimates, but symptoms of ADHD are much higher than that, and clinic samples, 41 to almost 80% of persons with spectrum disorder may have ADHD symptoms. We talked about the diagnostic overshadowing. What is ADHD and what is autism? For example, I have kids who are very distracted and daydream, but I think that they're internally distracted by their sort of preoccupation. Sort of trying to sort that out can be difficult because there really aren't great measures to specifically differentiate it. But I certainly do consider, and I certainly do treat persons with autism when their attentional problems or hyperactivity are above and beyond what you expect for developmental level. And it's important to identify and not just subsume it under autism because medication can be effective. The RUP group is the Regional Units in Pediatric Psychopharmacology, and that group studies medications in persons with autism, which is otherwise hard to find in the literature. These do randomized clinically controlled trials looking at medications for persons with autism and not just using medications off-label, which we often do. So they looked at methylphenidate, which is Ritalin, basically. They're all different long, short-acting forms of that. And if I had a child who had ADHD without autism spectrum disorder, I'd have an 80 to 90% chance of being successful with treating that child with a stimulant medication. In autism spectrum disorder, that is less true, but certainly about 50% of kids who have ADHD symptoms and autism do respond positively to stimulant medications. And I usually use the methylphenidate class, but not, there's a dextroamphetamine class as well. You can use either one. So medication can be effective. And I used to think that I could predict who was going to have a problem with it. And I found out I can't. The stimulant medications help everybody focus. So if you're hyper-focused, I used to worry that you would become more hyper-focused and have more OCD. Sometimes that happens, but even in our kids who have a lot of sort of those perseverative things, it doesn't always happen. The nice thing about the stimulant medications is you're going to know within a dose or two, or at least a day or two, whether they're going to work or whether they're not going to be tolerated. In my practice, I also use, and you may have seen patients, your clients on, alpha-2 adrenergic agents like guanfacine or clonidine, which can be better tolerated in persons with autism and are also approved for ADHD. Anxiety is also very common, and unfortunately, there's not one great drug that treats both ADHD and anxiety because many of our children have both those things. And so at least 40% of youth with autism spectrum disorder have anxiety disorder. Other estimates are, again, wide-ranging but high. Most common are sort of specific phobias, social anxiety, obsessive compulsive disorder. Generalized anxiety, GAD is generalized anxiety disorder, is also much higher than the general population, and anxiety often presents as irritability in kids. There are sort of common anxieties, things that are typical of other children who don't have autism who have anxiety, but there are also some specific autism-specific anxieties like idiosyncratic specific phobias, some sensory-related anxieties, and anxiety about uncertainty and change. There's not a lot of research. There certainly is research on behavioral interventions like modified cognitive behavioral therapy. In our clinics, we also, for young children with autism, parent-child interaction therapy can be very helpful. There's not a ton of research on medication. I certainly use some of the SSRIs like Prozac, citalopram can be helpful. There's also Buspar and mirtazapine. So there are other medications, and some of these are pretty familiar to pediatricians, like Prozac and Zoloft for anxiety symptoms. Others are less so. Physicians are fairly comfortable with ADHD medications, and even in autism, but are less comfortable with some of the other medications used in anxiety. And depression is also a concern, and it's sometimes, again, hard to measure. We don't necessarily have great ways of looking at it, but there are increasing number of reports about high rates of suicidal ideation and attempts. And there have been some recent recommendations, and it's in your bibliography, to do some sort of universal suicide screening in especially adolescents who have autism spectrum disorder and intellectual disability. Limited research on medications, again, in children in general, but certainly in autism specifically. The SSRIs, again, like Prozac or Zoloft, the recommendation is to start at a really low dose and go slowly, and that's what we do. So in the algorithm, it talks about consider psychopharmacologic interventions for irritable and problem behavior. The pathway also has this paragraph that talks about N-acetylcysteine, which is an over-the-counter, used to be over-the-counter, is not anymore, and clonidine. And so there are some things that you might try before you got to Risperdal or Abilify. But I think after you go through this algorithm and you do address the things that you have addressed, there are children who do benefit from atypical neuroleptics, particularly if safety is an issue. And sometimes I do what I think of as sort of emergency treatment with Risperdal or Abilify, with the hope that actually after we get other stuff in place and some time that we can stop those medications. But there are children who would lose placements and who are really sort of put other people at risk, where those medications can be very helpful. But as you can see with the irritability pathway, that's sort of at the end of thinking through all these things and not at the beginning. So what we don't want to see, and I have seen, is I've seen, really young kids on Risperdal or Abilify without really having any understanding of what the triggering behaviors are, or what's going on with potential other co-occurring conditions. So key takeaways. Children, youth with significant change in behavior should be evaluated for contributing medical cause. There are genetic syndromes who have certain behavioral characteristics, and that can help guide treatment. We follow a number of persons, for example, with Fragile X syndrome, and there are some specific medications even for Fragile X syndrome that we think about for that. Prior to starting medication for severe behavior problems, assessing factors should be completed. And again, we want to avoid the first response of putting a child on an atypical neuroleptic without really thinking through what might be causing the behavior. Children with neurodevelopmental disability have increased risk of co-occurring conditions, really common and also need to be considered. And medication management can be helpful in kids who have severe irritability and problem behaviors when you haven't been able to manage them with all the other tools that you have in your toolbox. So that is the end of my presentation. And those are my references. And Tiffany, I think that you're on.
Before we get to Tiffany, we did have some questions in the chat for you, Dr. Ellerbeck.
Okay.
The first question was from Linda. She asked, how can you do a good ROS with a nonverbal kiddo?
That is challenging. And, sometimes you really have to do a really good physical exam, not just a review of systems. So when I have kids who are nonverbal or who have, especially again, if they've had real change in behaviors, I look for potential things that may have changed. So with review of systems, for example, I mean, sometimes I put kids on medications that cause constipation. And so I'll certainly, when I look at GI things, I'll look at that and we'll talk to parents. The child may not be able to report that he's constipated, but parents will often have an idea. Dental things, for kids who have self-injurious behaviors, sometimes where they're doing self-injury can be a helpful clue, hitting ears or face. Some kids who have, especially all of a sudden onset of self-injurious behavior, I will have them see their pediatrician and see a dentist to look and see if there's anything there that we can't find. So not only, I mentioned good review assistance, but also a good physical exam may be really helpful. But it's hard.
Thank you. Our next question is from Juan, I believe. And Juan asked, what are the general interventions to help with sleeping and eating issues?
Okay, for sleeping issues, sleep hygiene is important for what we call sleep hygiene, is important for all kids who have sleep disorders. So when kids, sleep routines and how you go to sleep, and are you able to sleep with yourself without the TV on in the room and all those things, those interventions that are important for every child are important for kids with autism spectrum disorder as well. And autism is hard because parents often resort to sleep practices that lead to night waking and lead to sleep problems because they're exhausted, and you have a routine for bedtime, but the routine has to be very specific and it has to go exactly this way because you have autism, or there's a lot of anxiety around sleep. So thinking through, is the sleep hygiene okay? Is the child able to go to bed by himself without parents laying by him in the room? And then working towards that is important. And again, we do that for kids who have sleep disorders of all kinds, not only kids who have autism. Looking at anxiety is also something that treating anxiety sometimes, or ADHD sometimes, also really helps with sleep, especially sleep onset. Melatonin has a good evidence base for helping with sleep onset, and I prescribe it frequently in my practice, or recommend it frequently in my practice. It does not help so much with the night waking, the kids who go to sleep fine, but they're up multiple times a night. Extended release melatonin can sometimes help those kids, but there are kids who are just, they don't need to see sleep nearly as much as their parents do. They 4 to 6 hours, and that's very challenging. And then there are kids who have syndromes who also really have specific syndromes that are known to be associated with a lot of sleep problems. Some of those kids I send to a sleep clinic if I can't figure it out. There also are kids who have, just like other kids, obstructive sleep apnea. They have, big tonsils, they snore at night. So looking for those medical things first, treating sleep hygiene, considering melatonin, and then sometimes you'll need referral.
And the same question for eating issues.
Restrictive eating, yeah.
Yeah.
Restrictive eating. What I do is I go through and see first if the child is safe. So there are kids who are picky eaters, and they may be picky about how food is presented. It can't touch, or they have to look a certain way. But if you review, they're getting enough protein. They're getting fruits and vegetables. There may be only certain fruits and vegetables, but they'll get them. Or so you go through what they're taking in, and nutritionally they look okay. I'm a little less worried about those kids than the kids who only eat white foods, who never touch a fruit or a vegetable, whose parents are using Pediasure if they can get them to take that. Kids who eat less than 10 to 20 foods, I often nutritionally at risk, 20 different kinds of foods. And expanding food choices can be quite challenging. Some of the kids we see seem to be very sensitive to textures of foods. Other kids we see are very sensitive to appearance, even to the effects of, like, it has to be a certain brand, or if it has a spot on it. So trying to help parents think through that. But I often refer to our feeding team, and we have a feeding team here that actually also sees kids by telemedicine, because there often has to be a very gradual introduction to foods, where you actually first look at the food, then you touch the food, then you might put the food to your mouth, and that can take considerable expertise and time. So speech and language therapists and occupational therapists often have that expertise. In our clinics, we have a team that has a dietitian and a psychologist and an occupational therapist on it. And I frequently refer to those kids who I am worried they're not growing, or if they are growing, I don't know how they're growing, because they're living on love and air, that they really don't have what seems to be enough vitamins and minerals or protein in their diet. So.
Thank you. And I think we have one more question. How common is prescribing psychotic medication to ASD children 8 to 10 years old, specifically talking about risperidone? I think I'm saying that right.
I don't know exactly how frequent it is. I know that I certainly see kids come in because they have an autism diagnosis, and because the only approved medications for autism spectrum disorder are Risperdal and Abilify. Everything else we kind of use off-label. I mean, there are some studies, like I mentioned, for medications for ADHD and for anxiety, but the only FDA approved for autism specifically are the atypical neuroleptics, which I think is unfortunate, because I think that for some providers, that seems, well, it's FDA approved, that would be where we should start. And so but I don't know the frequency. I know it's more common in foster care. So if you have a child who's been in foster care, there's certainly more higher rates of use of atypical neuroleptics. But I don't honestly know on a population basis what the rates are.
Awesome. Thank you for answering those questions, Dr. Ellerbeck. So now we will move on to our case presentation.